My topic of discussion for today is the imaging in pediatric neck masses. So I will be considering to show you cases up to the age of 18. And the most important point is that pediatric neck mass is a quite commonly encountered entity, and it is one of the common indication for the imaging. And it has a broad range of etiology. It can be congenital conditions. It may be because of infections or inflammatory conditions, lymphatic or vascular malformation or vascular tumors. It may be traumatic. It may be neoplastic, various form of benign and malignant neoplasm that can present with a mass in that of the neck. And we have the imaging modality most commonly used is that of the ultrasound because it is widely available, and particularly in children, the superficial lesions can be well evaluated with that of the ultrasound, particularly of that of the various salivary glands, the various lymph nodes, and ultrasound functions as an initial modality, and some form of cross-sectional imaging may be necessary in few cases, particularly to delineate the extent of that of the disease, and in some cases also for diagnosis. As far as cross-sectional imaging are concerned, MRI are better modality in children because of the better soft tissue resolution, and obvious there is lack of ionizing radiation. But CCT is also the workhorse, and that is used often for evaluation of many neck masses because of its wide availability, and it can be done in a very less amount of the time without requiring sedation, particularly in children. That can be useful. So before going to what could be a neck mass, you should, as a radiologist, you should know few important clinical points, and you have to assess few imaging points. So the clinical point, most important, what is the age of the patient, what is the clinical presentation of the patient, whether it is an acute onset or it is a chronic or a subacute onset, what is the rapidity of that of the onset or the development of the neck mass, and is there any associated feature, and is there any systemic manifestation also, because a neck mass could be a presentation of various systemic disease as well. And as far as imaging is concerned, you have to look for what is the location of the lesion. First point, you have to localize the lesion, whether it is midline neck or in the lateral part of the neck. And if we can localize the lesion to any of the deep neck space, or if it is a lesion, it is involving multiple neck spaces, so that our differential diagnosis is based upon this approach. Then we have to characterize the lesion. Most important, we have to know whether it is a cystic or solid lesion. That can be very well appreciated on a simple ultrasound examination. And then the enhancement feature, signal intensity, all of this we have to take into account. And along with that, the associated finding, is there any bony changes, and is there any mass effect, and what is the complete extent, we have to evaluate and give our diagnosis as well as that of the staging if it is required. So as far as cystic lesions are concerned, we divide broadly into whether it is an anterior midline cystic lesion or it is a kind of lateral neck cystic lesion. In the anterior midline location, you have to look for the entities. You may come across with entities like ranula in the floor of the mouth, thyroglossal ducts in the anterior midline neck, dormoid and epidermosis, they tends to localize in that of the midline of that of the neck, and that can present with a cystic mass in children as well. And as far as lateral neck is concerned, most common cystic lesion you may encounter is the branchial cleft cyst. Others are lymphangioma or lymphatic malformation, and various form of that of the slow flow or venous vascular malformation as well. And as far as solid lesions are concerned, so the most common cause of the solid neck mass in a children is actually lymph nodal origin. So before going to start your evaluation, to first exclude if it is a solid lesion on ultrasound, whether it is a lymph nodal origin or not, then your differential diagnosis based on that. So if it is a lymph node, it could be a reactive lymph node because of that of the reaction to that of the adjacent, some infection is going in that of the adjacent structure, and the lymph node just got enlarged, and that can present with a palpable neck swelling. Second, the lymph node may be primarily involved by that of disease, for example, in tuberculosis and other forms of microbacterial infection. So that is called as that of the lymphadenitis. Malignant lymphoma can involve the lymph node. Besides this, the other group disease is that of the histiocytic disorder, and the most common among is that of the LCA. So you have to just mention these things in your mind before proceeding if it is a lymph nodal lesion. So if it is a not lymph nodal lesion, solid lesion, so the most common malignant soft tissue tumor after a lymphoma is the rhabdomyosarcoma. You may get leukemic deposits anywhere in that of the neck, and also the lymphoma can involve outside the lymph node, other soft tissues of the neck can be also involved by that of the lymphoma. You may get hemangioma and other vascular tumor. You may get neurogenic tumor like schwannoma, neurofibroma, paraganglioma. You may get salivary gland tumor, benign or malignant, more commonly benign. And you may get many inflammation and infective conditions, including involvement of the salivary gland. Most common is that of the parotitis or abscess. So these are all the entities. You have to look for what is the chronicity of that of the disease onset and what is the clinical presentation. Along with that, your imaging findings. So now we will go to multiple cases that I would like to highlight. How you approach the cases and how you make your diagnosis. So this is a 1-year-old female child presented with fever with hepatosplenomegaly. There is swelling all of the body as well as that of the left leg, and the patient presented with a left-sided ear bleed as well as that of it. There is a swelling, palpable swelling in that of the periauricular region, and there is obvious inflammatory signs were there on clinical examination, and there are some lymphoblastic cells in that of the peripheral spine. So the patient presented for a CECT of that of the neck evaluation because of the symptom. So what we find that there is a peripherally enhancing. You can see the peripheral wall is enhancing. There is the center area is that of the kind of necrotic non-enhancing content is there, and it is showing some air foci. It is in relation to that of the left side of that of the temporal bone, lateral to that of the mastoid cortex, and you can see some subtle erosions in that of the cortex, and you can see also some periosteal reactions are there, and it is also extending to that of the left parotid gland. The parotid gland is also bulky. Along with that, there is this represents a abscess collection. Along with that, there is some bony changes. And you can see there is bilateral cervical symmetrical lymphadenopathy as well. So this is a case of skull-based osteomyelitis. Also, you can call it as a necrotizing otitis externa. It is also involving the external auditory canal as well. There is thickening of that of the soft tissue surrounding that, and there is involvement of that of the skull base. So it is different from that of the mastoiditis, because in mastoiditis it is only the mastoid air cells that is involved, but the cortex is intact. But in this case, the cortex is eroded, and you can see one of the earlier feature of that of the inflammatory change. You also get in the region of that of the temporomandibular joint, just posterior to that of the mandibular condyle. You can see the stranding of this fat. You can see the clear fat here. So it is one of the early sensitive signs for the detection of that of the skull-based osteomyelitis. So you have to have that degree of clinical point to find out what is the actual diagnosis in this case. So microbiological evaluation was positive for a fungal etiology. So there was also bilateral automastoiditis as well. So this was on bone marrow biopsy. This was came out a case of ALL. So the patient is immunocompromised, and there is fungal abscess along with that of the skull-based osteomyelitis as well. So this is the case of a 2-year-old boy. Where the patient presented with a large mass in the right pinna, pre and post auricular region, which is progressive over a period of that of the 2 months, and it is progressing over the period of last 20 days. It's a very rapid progression. So and there is also associated pain and tenderness. So the clinical suspicion was some kind of abscess or some kind of inflammatory lesion. So what we got, this is the CT that the patient has done previously before coming to the presentation hospital. So there is some ill-defined heterogeneously enhancing mass lesion in relation to that of the right temporal bone, and you can see there is obvious bony erosions are there in the bone. And on MR, what we found, we get a very large ill-defined infiltrative T2 hyperintense lesion noted in right masticator space. It is also involving the right parotid space as well. You can see the parotid here in the left side. There is the involvement of the right parotid and masticator space, and it is also showing extension into that of the intracaliar compartment with involvement of that of the temporal region with erosion of that of the skull base. You can see here. And the lesion shows a very heterogeneous kind of enhancement is there. You can show here there is some necrotic cystic areas with diffusion restriction. So this is a case of rhabdomyosarcoma proved on biopsy, but this is actually the most common soft tissue malignant neoplasm in the children after the malignant lymphomas. And there are 3 different types of rhabdomyosarcoma in the head and neck that is listed. One is that is the most aggressive with a poor outcome is called as that of the parameningeal type, where there is involvement of that of the meninges and involvement of that of the skull base along with that of the intracranial extension. Non-parameningeal, when it is away from that of the meninges and the skull base, particularly if it is localized only to that of the parotid or oral cavity, and another is that of the orbital. So these are the three types, and you, when you are getting any neck mass like a infiltrative malignant looking, you have to have that in your mind. And this is another case. This is also a case of rhabdomyosarcoma. The importance of showing this case is that this is one of the tumor, malignant tumor in the pediatric population that shows a perineural tumor spread, and that is also important. You have to look for that and you have to comment, because once there is perineural spread, even if there is no direct extension into that of the intracranial compartment, that becomes a parameningeal. If it is perineural spread is along the skull base, that become a parameningeal type, and the prognosis and the treatment varies. So in this case, these are the CT images. You can see there is widening of that of the right mandibular canal. You can show this soft tissue is extending that. There is also widening of that of the right foramen oval, and there is enhancement around this. So there is extension along the mandibular nerve as well as that of the infraalveolar nerve. So this is the pre-treatment image. This is a very large mass. This is the post-treatment chemo. There is reduction in the mass lesion, but you can better appreciate this perineural tumor spread. So this is again a parameningeal variety of that of the rhabdomyosarcoma involving masticator space. This is another case. This is a 5-year-old child. Similar presentation. It is this rhabdomyosarcoma usually presents as a T2 hyperintense lesion. There is few thin internal septae, kind of hypointense septae are usually there, and they in this case there is also intracranial extension are there. So important point is that the role of imaging is not only in the diagnosis, also for response assessment. So this case undergone chemotherapy, and you can see that there is, the lesion is quite reduced. There is some residual lesions is there in that of the right temporal region, in the masticator space and parotid region, but majority of the lesion has been reduced. So there is partial response. So this is one of the role also of imaging, not only the diagnosis. Then a similar kind of presentation is a 12-year-old boy, known case of AML on remission, presented with left ear discharge and left facial nerve palsy, and there is also a mass or swelling in that of the periauricular region. So again, from clinical point of view, it was kind of infective, inflammatory kind of thing. But what we found on that of the CCT, you can see there is a homogeneously enhancing soft tissue. It is centered over the left temporal bone, mostly the mastoid part. And you can see that there is a permeative lytic kind of that of the bony changes, because the bone outline is relatively maintained, but there is extension of the soft tissue outside of this bony outline of that of the cortex of this mastoid bone into the adjacent soft tissue. So this permeative kind of bony changes along with his soft tissue mass centered over that is more likely seen in a leukemic deposit, and sometimes also the lymphomatous deposit as well. So this was a case of AML. So this was a relapse of AML as a mass in that of the preauricular region. So come to the next case. This is a 17-year-old boy which is presented with a slowly growing swelling in that of the right side of the neck for the last 3 years. So what we found that before going to this type of swelling, first try to localize where the lesion is located, because this is looking obviously benign kind of. It is a very encapsulated kind of oval to elongated lesion, and it is localized to that of the right carotid space. We will always compare with that of the contralateral side in the head and neck. And what is the pattern of displacement of the vessel? When a lesion is located in the carotid space, you have to locate for that of the what is the pattern of displacement. You can see here the two vessels. So these are the internal and external carotid vessel. They are anteromedially displaced. You can see the internal jugular vein. So actually it is compressed and displaced posterolaterally, and the lesion is T2 hyperintense, and it shows a fairly homogeneous to mild heterogeneous kind of intense enhancement is there. And you can see the elongated appearance of that of the lesion on that of the sagittal image. And here you can see that this is actually the vein which is displaced posteriorly. This is the inferiormost part of that of the lesion. This is the vein which is starting to displace posterolaterally. So this is the case of that of the vagal schwannoma. So why it is a schwannoma and why it is a vagal origin, you have to define that. So in the carotid space, there are the two most important lesions that occur. One is the schwannoma, or you can write it is as a benign Nopsi tumor, and the second is that of a paraganglioma. So the thing is that you have to look for what is there any presence of that of the high velocity flow void within the lesion on T1. So we did not find anything on our images. And we have to look for enhancement dynamics. So whether it is a early enhancement with washout or with a slowly progressive kind of enhancement. And also, you have to look for, is there any presence of a target sign on T2-weighted image? That is the classical of a neurofibroma. I will show a case. So in this case, one important point you have to remember that the schwannoma, the benign offset tumor, they tend to show a very good kind of or intense kind of enhancement in the delayed phase image. Particularly if the images are acquired beyond 60 seconds, you will get a very dense kind of enhancement. It is because of that of the contrast pooling from that of the slow venous drainage of that of the tumor. But at that moment, a paraganglioma, it will show a intense early phase enhancement, and in late phase, it will rather show a washout. So always a dynamic, if you are doing a MR, always a dynamic imaging is helpful in evaluation of the enhancement pattern. And second thing, you will always look for that flow voids, because that is seen in that of the paraganglioma. So this is the case of that of the vagal schwannoma. So why it is vagal schwannoma, I will discuss what is the pattern of that of the vascular displacement that will help in you narrowing down the differential diagnosis. So this is the illustrative diagram of that of the left carotid space. You can see the vagus nerve is posteriorly located midline in between the CCA and or the CCA or the ICA and the internal jugular vein. So when there is a mass arising from that of the vagus nerve, so it tends to grow here and it tends to separate them. So therefore, the internal carotid or the common carotid, it will be displaced anteromedially, whereas this will be displaced posteriorly or laterally. So whereas if it is a schwannoma arising from that of the sympathetic chain, so sympathetic trunk is located here, so it will cause a kind of anterior displacement of this and more so a lateral displacement of that of the IJV, but not rather a posterior displacement, but it will cause more anterior displacement or maybe sometime also anterolateral displacement of that of the carotid artery rather than a anteromedial displacement. So these are the points that that's how you localize a mass to the carotid space. Then you characterize whether it is a schwannoma, benign offset tumor, or paraganglioma, and if it is a schwannoma, then what is probably the knob of origin you can define on that of the images. So this is another case. It's a 16-year-old girl presented with slowly growing swelling in that of the left side of neck. You can see that you are getting some flow voids in the lesion. You can see some flow voids, hypo channels, and the lesion is very intensely enhancing. Again, the lesion is localized to that of the left carotid space, but it is located above the level of that of the carotid bifurcation. It is completely encasing the both internal and external carotid artery, and it is extending, reaching up to the skull base. So this is a case of vagal paraganglioma. Other types of paraganglioma that can occur is that of the carotid body tumor, that usually in the will be within the bifurcation of that of the carotid artery, and that tends to separate the ICA and ECA. But in this case, the vagal paraganglioma, that will not cause that much separation. That will only cause encasement, and rather that will cause a anterior kind of displacement of the vessel, just like we have shown that vagal schwannoma, that will cause a anteromedial kind of displacement or sometimes the encasement. So this is another case. This is a 16-year-old boy with right-sided neck swelling. So what we found in this is also another lesion localized again to that of the carotid space as well as that of the parapharyngeal space or the uh, the parapharyngeal fat space is you can see here. And the lesion is quite ill-defined. It's a kind of you can see the typical targetoid appearance, that is the peripheral T2 hyperintensity and central T1 central T2 hypointensity, which is characteristically seen in that of the neurofibroma, or a more typically a plexiform type of that of the neurofibroma in this case, because it is a quite ill-defined infiltrative kind of the lesion, and it is encasing the vessels, not much mass effect, but it is encasing the vessel. So here this targetoid sign is very much important, and this is the T2 fat set, and these are the enhancement, heterogeneous enhancement, and also some kind of targetoid enhancement is also there. So this is a case of neurofibroma that is quite typical if this sign is found. This is an interesting case. This is an 11-year-old girl presented with a right-sided proptosis, and there is a right preauricular swelling which is slowly progressive for last 20 days. And the patient presented with the MR for MR. So what we found there, there is a irregular thick nodular peripheral kind of enhancement, and there is some necrotic non-enhancing collection or necrotic area which is centered in that of the right greater wing of that of the sphenoid. You can see the left greater wing, you can see the right greater wing of sphenoid is not visualized. The lesion is somewhat T2 hypointense, and this is the T1 weighted image, and you can see this irregular dirty kind of thick irregular enhancement, and you can see there is intracranial extension into that of the right temporal lobe, and along with that there is surrounding edematous changes in that of the temporal lobe. So the lesion is localized in this case into the bone. You can see the bone here, the bone is not there, And this kind of thick irregular enhancement with a T2 hypointense probably think you in the direction of tubercular etiology. Typically, the tubercular caseating granuloma, they are T2 hypointense, and tubercular osteomyelitis can involve the base of the skull. So what we did is there was also some preauricular swelling. So the cause of this preauricular swelling was actually there are two enlarged necrotic kind of lymph nodes are there. So these nodes were targeted by FNAC examination, and this etiology was proved to be of tubercular origin. And we also did the CT scan. You can see these bony changes, irregular lytic changes are there along with some periosteal reaction, and there is some mass-like consolidation in that of the right side of that of the lung, as well as there are some necrotic mediastinal lymphadenopathy, and the patient was treated on ATT. This is the 2-month follow-up. There is a reduction in that of the, it is now become more homogeneous kind of enhancement, and there is there is also resolution of that of the lung changes, and also there is complete almost resolution after the completion of that of the 7th month of that of the ATD. So tuberculosis can present with a variable unusual pattern, and in Indian subcontinent you always look, you should always have a high degree of suspicion for tubercular etiology. It can affect any part in the head and neck as well. So then come to that of the most common pattern of tubercular involvement is actually the lymph node that we'll encounter in a everyday practice. So this is a case of typical necrotic. You can see this internal necrosis. This is the total node, and you can see this more hypoechoic area, though is showing some post-acoustic enhancement, and there is some echogenic content is there. So this is a enlarged lymph node, necrotic. So this is a very typical of tubercular lymphadenitis, and this is a enlarged lymph node, but there is maintained fatty hilum. You cannot see the fatty hilum here, but this is just enlarged and there is some vascularity. So this is a kind of reactive lymphadenopathy. So you can't determine what is the cause of reactive lymphadenopathy. If it is subsiding on a course of antibiotics, so it is probably some other infection. But if it is chronic, you always sample that, and if it is a necrotic, you have to sample that to prove that whether it is a tubercular etiology or not. This is another case. This is a 6-year-old boy with a right-sided neck swelling. What you find is that there is multiple enlarged lymph node. They are rounded in appearance. They are quite homogeneous, studded in that of the right side, a discrete kind of lymph node. And there is also multiple intra-abdominal retroperitoneal lymph nodes. So this is a very classic case of Hodgkin's lymphoma involving intra-abdominal mediastinal as well as that of the cervical lymph node. And this is the post-treatment images on after chemotherapy. The nodals has become relatively oval in shape. They are the thickened as well, and there is some appearance of that of the echogenic hilum here. So this is the post-treatment images. So if it is a very homogeneous lymph nodal mass and rounded, so always keep the possibility of a Hodgkin's lymphoma in your. So this is another case, similar kind of multiple enlarged discrete lymph node, homogeneous in appearance with a very high FDG optic. So FDG PET is done for that of the complete staging of the disease in cases of lymphoma. This is another case. This is a 2-year-old girl child presented with multiple bilateral neck swelling and bilateral ear discharge. So what we find there is symmetrical bilateral cervical lymphadenopathy, and there are multiple lesions involving the skull base, particularly that is involving the bilateral mastoid and temporal bone. Here you can see the peripheral enhancement. You can see the lesions here. These are the lesions here, and you can see also one of the lesion here in that of the right skull vault in the temporal region. This is also peripherally showing enhancement. So in addition to that, the patient was also subjected to a CT abdomen because there was some lymphadenopathy on ultrasound examination. You can see the intra-abdominal lymphadenopathy, and on CT images you can see there is a collapse of that of the T5 dorsal vertebral body, and this is the classic vertebra plana. And all of these constituting your diagnosis in this case, it is a case of Langerhans histiocytosis, and it was proved upon histological examination of that of the enlarged lymph node. So when bilateral symmetrical enlarged lymph node is there, leukemia, lymphoma, histiocytosis, all of these things to be considered in your differential diagnosis in children. So this is a case of LCH. This is another case. Is a 6-year-old boy with bilateral parotid swelling. So children, they may present with parotitis and parotid swelling quite often as a clinical presentation. On imaging, you can see that bilateral parotids are enlarged homogeneously. There are multiple small hypoechoic nodular focal areas are there, more so in the left than right. And there are few enlarged necrotic lymph node. So this was a case of granulomatous parotitis. This just present like that. and this was proved from the FNSC from that of the lymph node. But this appearance is quite non-specific. This can be seen in any form of chronic recurrent parotitis, granulomatous infection, HIV cellopathy, and as well as that of the autoimmune Sjogren's disease. So the imaging morphology is non-specific. So therefore, clinical and image-guided FNSC will helpful in the diagnosis. This is a classic case of a acute parotitis in a 3-month-old girl, right parotid swelling, pain, full swelling, 15 days. You can see the enlarged gland. This is the left normal-sided gland. This is the enlarged hypoechoic gland, both superficial and deep lobe enlarged, and increased vascularity. Acute parotitis, always look for if there is any parotitis, look for is there any developing abscess or not. Then this is another case. This is a 15-year female presented with a painless swelling in the left preauricular region. So what you find, there is a very well-defined capsulated lesion, peripheral hypointense capsule, T1 hypointense lesion, T2 hyperintense, very hyperintense, even more than that of the CSF, no diffusion restriction, and a kind of heterogeneous enhancement. So this is a kind of benign kind of appearing lesion involving the left superficial as well as that of the deep lobe of the parotid. So when you come across a parotid space lesion in the children, first differential is always a pleomorphic adenoma. It is the most common benign parotid tumor in children. And FNSC was proved of that. One important point is that this pleomorphic adenoma is showed a progressive pattern of enhancement. So if you do a dynamic MR, you will show a progressive pattern of enhancement without obvious washout or in the delayed phase. So these are the features that strongly suggest a pleomorphic adenoma. So before you going to consider other diagnosis, first rule out pleomorphic adenoma if it is a parotid gland lesion. So it's very hyperintense, well circumscribed sharp margin, lobulated contour, and a progressive delayed kind of enhancement. But pleomorphic adenoma can have a very variable kind of enhancement presentation. This is a case of 9-month-old infant. Progressively increasing mass in the left side of the neck for 6 months. There is a very large mass here. In this case, it is involving the left parotid. You can see the right parotid here, left parotid, and it is also involving the deep lobe and projecting into that of the parapharyngeal space, and there is a bulging in that of the oropharyngeal cavity as well. So again, this is a T2 hyperintense, and it is a case of pleomorphic adenoma. It was showing restricted diffusion, so it is a cellular form of pleomorphic adenoma, and it can be also seen in that of the infants as well. This is a 3-month-old baby with increasing left cheek swelling after few weeks of birth. So when this type of lesion, if it is a congenital lesion or if it is developing few weeks of the birth, so you have to look for few sets of diagnosis, like whether it is a vascular tumor kind of hemangioma or whether it is a vascular malformation, a venous or a lymphatic kind of malformation. So what we found, we can found the left parotid gland is entirely enlarged, and there are few hypoechoic vascular channels that are taking the intense color flow here. And on the CT image, you can see the entire left parotid gland is enlarged and with a homogeneous kind of that of the enhancement. So this is a very classic presentation of infantile hemangioma involving the parotid gland. The normal parotid gland is not visual. It is just this intense kind of enhancement. So if you are getting a solid kind of mass on ultrasound with high arterial flow pattern, and you are getting this kind of intensely enhancing soft tissue appearing lesion with a typical clinical presentation, so first thing will be hemangioma. So another case, this is a case of 2-year-old boy with an increasing right cheek swelling since birth. So it was present since birth. So what we find, again, there is a soft tissue nodularity involving the skin and subcutaneous tissue in the right preauricular region. And the lesion is also involving the superficial lobe of that of the right parotid. And it is showing intense kind of that of the enhancement on the post contrast, and it is again T2 hyperintense lesion, and this is the clinical presentation of that of the lesion. So this is a 2 year. So this is again also is a soft tissue vascular tumor. So most common soft tissue vascular tumor, it will be a hemangioma, and it is a form of non-involuting. It is not an infantile. This will be a congenital hemangioma because it was since present since birth, and it is not yet involuted after 2 years also. So it is a non-involuting form. So another form of that of the hemangioma is called as that of the you can called rapidly involuting hemangioma, that is called RICH. Another is that of a non-involuting hemangioma. So these are the pattern of that of the grayscale ultrasound and the Doppler parameter. And once you get a vascular lesion, you have to always look for whether it is a vascular malformation or that of the vascular tumor. So this the vascular malformation, so they will not present with a soft tissue kind of lesion in the ultrasound. Rather, they will present with some vascular channels, ill-defined infiltrative kind of. It can be multicystic in case of that of the lymphatic malformation, or if it is a venous malformation, there will be some vascular channels, or there may be some ill-defined soft tissues, but not a very well-defined kind of soft tissue and enhancing that is seen in that of the classic hemangioma. So these are the different cases in the pediatric population. So once you are looking such kind of lesion, always try to look for one thing that is called the phlebolith, because the presence of the phlebolith, which are the calcific deposit within the venous channel, this is one of the characteristic imaging feature of that of the venous malformation. So when you find a phlebolith, so it is essentially a slow flow venous vascular malformation. You can see here there is a in the right temporal region there is a T2 hyperintense lesion. You can see this hypointense flow voids, that is the phlebolith here. You can see here in that of the root of the neck, there is a ill-defined lesion and there is presence of these flow voids. This is the phlebolith. So the presence of phlebolith, and along with that on the delayed phase images, there is a progressive kind of enhancement. Early phase, there is less enhancement. On the delayed phase, there will be progressive kind of enhancement. So this is a typical feature of venous vascular malformation. Then we'll go to the next group of that of the vascular malformation. That is, it is a case of 2-year-old boy with a large swelling in that of the left side of that of the neck since birth. So usually the vascular malformation, they are present at the time of birth, whereas that of the infantile hemangioma, they developed after 2 to 3 weeks of the birth, and they show a course of progressive growth in the first year of life, and then this course so involution over a period of up to 9 or 10 years. Whereas that of the vascular malformation, they tends to grow with that of the growth of the child, whether it is a lymphatic valve malformation or whether it is a venous vascular malformation. So what we found on ultrasound, there is some large cystic, multiseparated cystic areas. So there is macrocystic as well as there are some microcystic areas. So these are apparently appearing solid, but these are the microcystic component. And on MR, you can also demonstrate the microcystic area as well as that of the macrocystic area. This is in that of the left side of that of the neck, and it is involving multiple spaces, the posterior neck space as well as that of the parotid space, and it is completely encasing that of the carotid vessels. You can see there is encasing but without any mass effect. So this is a very classic case of that of the lymphangioma or cystic hygroma, or also called as that of the lymphatic malformation. Similar case you can see in that of the parotid space. There is a cystic lesion, non-enhancing, encasing that of the external carotid artery in the superficial and deep lobe of that of the parotid and extending onto the submandibular gland. So this is another case of that of the lymphangioma involving the parotid. So venous malformation, they will show the delayed phase enhancement. Lymphatic malformation, they will not show enhancement. This is then come to other, what are the other kind of cystic lesion that can present in the pediatric age group. This is a 16-year-old boy presenting with a right preauricular swelling. So what we find is that there is a capsulated lesion, and on ultrasound you can get this thick internal echogenic content, like a paste-like content, and you can see the poster-acoustic enhancement. It may give a pseudo-solid appearance, but you always look for the poster-acoustic enhancement. And there is some peripheral hypointensity and central relatively iso-intensity on that of the T2-ated. So there is some, it's not very bright, and there is the content is showing some degree of restricted diffusion. So this is a case of epidermolysis. So epidermolysis, they tend to show this type of ultrasound picture, and they tend to show a restricted diffusion. Another case of the epidermolysis in that of the floor of the mouth. This is a slowly progressive swelling in that of the floor of the mouth in a 14-year female. You can see there is a midline swelling and it is showing restricted diffusion. If it is not showing a restricted diffusion, it is a simple fluid, then your diagnosis, it will be a midline ranula. Just like here, it is a, you can see in the right side floor of the mouth, there is a peripheral enhancing cystic lesion. And this is a very classic case of that of the ranula. These are nothing but that of the inclusion cyst in that of the sublingual and minor salivary gland in that of the floor of the mouth. Then come to the another case. This is again a cystic lesion. It is a 11-year-old child presented with right neck swelling and nasal obstruction. So this is a very benign appearing thin wall cystic lesion noted. So look for, when you found this type of cystic lesion close to that of the carotid vessel, always look for what is the location. It is located posterior to that of the submandibular gland, anterior to that of the sternocleidomastoid muscle, and superficial to that of the carotid. So this location is very characteristic of that of the second branchial cleft cyst, and it is the most common lateral cystic mass in the pediatric age group. So how to differentiate first versus second versus third branchial cleft cyst? It is based upon that of the location. First branchial cleft cyst typically within the parotid or close to the parotid. Second branchial cyst, it is located near the angle of the mandible, posterior to submandibular gland, lateral to the carotid space, and anteromedial to sternocleido, as I have seen. Third branchial cleft cyst, it is typically located in that of the posterior cervical space and typically in that of the left side. So just I will show one image. It is a case of the third branchial clefts. It is located in that of the posterior cervical space, and typically it is seen in that of the left side. So if you are getting a benign appearing cystic lesion, lateral neck space, look for location. You can diagnose what is the type of branchial clefts. Then come to, this is actually an adult patient. I have just included to show what are the kind of cystic lesion that can occur in the midline of that of the neck. So the most common is that of the thyroglossal doxis. It is present as a midline swelling close to that of the strap muscle in relation to that of the hyoid bone. It is infrahead in this location, and it is in between this thyroid membrane bulging into that in relation to that of the thyroid cartilages. So anterior midline lesion, cystic swelling, this is a thyroglossal doxis. And if you are getting a thyroglossal doxis, always look for whether the normal thyroid is there or not. Sometimes the thyroid may be ectopic in location, there may be lingual thyroid, the normal thyroid may be absent, and sometimes this thyroglossal doxis only may be the source of normal thyroid function. So always look for normal thyroid gland before, because if that is excised, the patient will go to hypothyroidism. This is another case. This is a 10-year-old boy presented with a small midline swelling. So you can see on the CT images, there is some intense homogeneous kind of enhancing structure in the midline anterior to the trachea, but this is not the normal location of that. It is looking like a thyroid, but it is not in the normal location. It is just a midline kind of oval lesion. It is above the normal location of that of the thyroid. And you can see also another similarly homogeneously enhancing in that of the base of the tongue. So this is the lingual thyroid and also ectopic thyroid above its normal location that can also present with a midline neck swelling. This is an interesting case. This is an 8-month-old baby presented with a left-sided nasal mass. So basically, the diagnosis is clear from the clinical examination. So MR or the CT examination is done to rule out what is the characteristic of that of the lesion and is there any intracranial communication. So you can see this is a very homogeneous fat density lesion in that of the left side nasal cavity, but it is only attaching into that of the nasal septum. There is no intracranial extension in this case. You can see the T2 hyperintense lesion. You can see the T1 hyperintense with a fat separation on the T1 fat side. So this is if you are getting a fatty kind of lesion in the face in relation to the nose, so it is a nasal dormer. Do look for what is the site of attachment. There is no communication into that of the intracranial compartment or no attachment to the skull base. This is another case. This is a 2-day-old neonate present with a very large left-sided nasal or facial mass. The diagnosis actually was clear from the clinical examination. This was a facial teratoma because there was some tooth-like structures are visible. So MR was done to look for again what is the communication with that of the intracranial compartment or not. You can see there is a very large ill-defined with a heterogeneous mass. You can see there is some fatty component is there which is showing suppression. This is the T2 fat side. This is the T1. This is the T2 image. You can see the fat images. You can see the cystic areas. And this is a case of congenital teratoma. And you can see the attachment is up to into the anterior skull base, just close to that of the foramen cecum, anterior to that of the cubiform fluid. So this is attached to that of the skull base, but there is no extension into the intracranial. So this attachment is important, and that is the role of imaging because the diagnosis is clinical. This is the interesting case. This is a 17-year-old girl presented with right-sided cheek swelling. So what we got on that of the CT that there is no pathology. What we found, the normal right-sided parotid gland is absent. You can see the normal left parotid gland. Rather, there is some parotid tissue is located ectopically anterior and superior to that of the or superficial to that of the muscle here. The masticator muscle, masseter muscle, you can see. So this is actually presenting as a cheek swelling. So this is the cause of that of the cheek swelling. So this is just a congenital abnormality, ectopic location of the parotid gland that presenting the cheek mass. And you can see the accessory parotid tissue as well in that of the left side. So this is just I have included last few cases. This is the juvenile nasopharyngeal angiography, one of the very common age group in the pediatric population, presented with a mass in the nasopharyngeal region with epistaxis. The classic location in this case is that of the close to the nasopalatine foramen here, and it goes to that of the pterygopalatine fossa. That is called the anterior bowing of that of the posterior maxillary sinus wall. That is called as that of the bow sign. And it can show extension to that of the sphenoid sinus. It can show intracranial extension. Always look for that of the extension of the mass. And this we may need to a preoperative angiography and embolization to reduce the blood loss. This is a case, this is a 11-year-old boy, the presented with a swelling in the floor of the mouth, but the swelling appears only after eating. So the patient came for a sciallogram study. When we injected the contrast into the submandibular gland opening, we get a very contrast pulling kind of cystic dilated structure here, and that is communicating with that of the submandibular gland dock. So this is actually cystic dilatation of the dock, and we could not get any obstruction. What is the cause of obstruction? We do a CT. On CT, there is a very small calculus noted as that of the opening of that of the submandibular gland. So this kind of swelling, it is not there always. It is only appearing after the time of eating, and we could able to demonstrate what is the cause of the swelling in this patient. And there is also associated sialoadenitis. You can see the fat standing, and you can see this dilated duct here. So this is the last case. This is a 12-year-old girl presenting with a right cheek swelling. So you can see here there is a lesion, expansile lytic kind of lesion involving the right ramus of that of the mandible. And you can see some enhancing internal septae, and it is giving a kind of soap bubble, or you can say a honeycomb type of appearance. And in this case, the important point is that these are arranged at right angles to that of the bony interface. There is no obvious bony erosion. There is no periosteal reaction. So this is a case of hemangioma involving that of the mandible. So other differential in this case could be ameloblastoma, but ameloblastoma, the cystic, and there will be also adequate amount of solid component is there in ameloblastoma. And sometimes odontogenic myxoma can also present with this type of similar appearance, but in this case that the septae will be more thin kind of tennis racket appearance, that is called. So, but the important point is that the arrangement of the septa at right angles to that of the bony interface is a feature suggestive of hemangioma.